Hello, everyone. My name is Daniela Kwiatkowski, and I'm the Manager of Training and Development here at MHS.
And I'm Jim Bonta, and the rumors are not true. I am alive.
Hi, everyone. And we are just wanted to say hello, say a quick hello. We are going to shut the webcam off, but we just wanted to show you that we are here at the MHS studio with our live webinar today. So I am going to close the webcam and we'll get started with today's webinar. So we'd like to thank everyone for coming to today's webinar, setting aside some time out of your busy day. Before we get started, just a few logistics that I wanted to go through. So you are on mute. We do that because there are quite a few people that are on the call right now. We want to make sure that everyone can hear our presenter. So we've put everyone on mute automatically, but we do want your questions. So we have set aside some time. Hopefully we'll have some time. There's a lot of great info today, but we're hoping to have some time at the end of the webinar to answer some questions from you. So please add your questions. There is a question pane in the panel on the right-hand side. Enter your questions at any time throughout the webinar, and we'll be sure to track it. If we get a chance to answer your question during today's webinar, we will do that. If not, please be assured that someone will connect with you afterwards to answer that question. As well, there is also a handout section on that panel on the right-hand side. There are a few things in there that you can download. Please do that now, and please do that before the webinar is over. Once we close out the webinar and everything is completed, you won't be able to download those things. So please do that now. We have had people in the past that have had trouble downloading PDFs. So if you do, please don't worry. We will be sending out the documents later on in an email. But if you don't want to wait till then, please download them now. And now a little bit about who we are for those of you who are meeting us for the first time. Multi-Health Systems is a global publisher of scientifically validated assessments in the clinical, education, public safety, and talent assessment markets. We are located in Toronto, Canada, and we've been in business for over 30 years. We publish assessments in over 50 languages and have a presence in 75 countries around the world, so we are truly global. And now a little bit about our presenter. Jim Bonta received his PhD in clinical psychology from the University of Ottawa in 1979. Upon graduating, Dr. Bonta was the chief psychologist at the Ottawa Carleton Detention Centre, which is a maximum security remand center for adults and young offenders. During his 14 years at the detention center, he established the only full-time psychology department in a jail setting in Canada. In 1990, Dr. Bonta joined Public Safety Canada, where he was Director of Corrections Research until his retirement in 2015. Throughout his career, Dr. Bonta has held various academic appointments, professional posts, and was a member of the editorial advisory boards for the Canadian Journal of Criminology and Criminal Justice and Behaviour. He is a Fellow of the Canadian Psychological Association, a recipient of the Criminal Justice Section's Career Contribution Award for 2009, the Queen Elizabeth II Diamond Jubilee Medal 2012, the Maud Booth Correctional Services Award in 2015, and the 2015 Community Corrections Award, International Corrections and Prisons Association. Dr. Bonta has published extensively in the area of risk assessment and offender rehabilitation. His latest publications include a book co-authored with the late D.A. Andrews entitled The Psychology of Criminal Conduct, now in its 6th edition with translations in French and Chinese. He is also a co-author of the Level of Service Offender Risk Need Classification Instruments, which have been translated into 6 languages and are used by correctional systems throughout the world. Welcome, Dr. Bonta.
Thank you very much for that introduction, Daniela. I have approximately 45 minutes to speak with you, and my goal is to try to help you understand the importance of theory for guiding assessment instruments and also for guiding rehabilitation programs. I'm also going to try to show you how the level of service instruments are based in theory. For those of you who may want to read more about this, further details and a more comprehensive presentation is available in the textbook, The Psychology of Criminal Conduct. My presentation is going to have essentially 3 parts. The first part will deal with the major theories of criminal behavior. These theories that I will describe very shortly will outline some of the weaknesses and strengths when it comes to the assessment of criminal behavior. I'm going to, in particular, speak about a general personality and cognitive social learning theory which underlies the level of service instruments. Next, I'll move on to the risk-need responsivity model, perhaps the world's foremost model in correctional assessment and rehabilitation. And I'm going to show you how important this risk-need responsivity, or RNR model, is to the assessment and treatment of offenders. Finally, I'm going to wrap up speaking about risk assessment and how it has changed over the years, and in particular, how the level of service instruments represent the most recent developments in risk and need assessment. Now, theory. I'm going to try to show you the link between theory and risk assessment. Some of you who are familiar with criminology may recognize this man, Cesare Lombroso, who is considered one of the fathers of criminology. He was also a medical physician in Italy. And one of the things that he would do autopsies on convicts. And from his work, from these observations, he learned that, or his theory was, there is a theory of atavism. Atavism means a biological throwback to an earlier evolutionary period. So when Lombroso looked at the brains of convicts, he thought they were strikingly similar to that of a rodent, an earlier part of our evolution. It was almost like having a Neanderthal stuck in today's world. So if you take Lombroso's theory of atavism, you can develop a risk assessment scale. And this is what it may look like. First of all, one risk factor would be large jaw and cheekbones. If you have this, you give them a score of 1. Eye defects. Ears standing out like a chimpanzee. Those are Lombroso's words. You can see the picture here. Now, some of you are starting to think that this looks remarkably like my cousin Joey. Very long arms. What's interesting about Lombroso's theory and this risk assessment that could be derived from the theory is you can have differential diagnoses. You can tell whether or not the person's a thief by the shape of the nose. A flat nose, thief. A beak-shaped nose, likely a murderer, perhaps because you have a ready-made weapon. Now, theories are simply explanations of behavior. They're just trying to explain something that you're observing. Ideally, a theory should also tell you a little bit about the cause of that behavior. I'm going to speak about 3 general perspectives: sociological criminology, forensic psychopathology, and the social learning perspective, general personality and cognitive social learning theory. Sociological criminology. I want to apologize to those who are well aware of these theories. I am oversimplifying it in a sense, but I want to get across my major points. Sociological criminological theories tend to look at the cause of crime being out there in society. It's not who you are, it's not your thinking, your emotions, your feelings. It's more where you are positioned in society. It's external sociological factors that are at the root of crime. And typically, these theories will look at the disadvantaged, the people lower in the socioeconomic scale that are most likely to be criminal. So let's take an example, Robert Merton's theory of limited opportunities. Merton observed American society, and his observation was that we are socialized to strive after certain goals in society, that we should accumulate money, we should accumulate property, prestige, right? The so-called American dream. Throughout school and our families are trying to encourage us that you can do it. How do you do it? You essentially do it by working hard and studying hard. These are the societal mechanisms for achieving the goal. Everyone can grow up to be president by working hard and studying hard. Merton also observed that these opportunities are not equally accessible to everybody. Not everyone has the best schools that they can go into. Not everyone receives the best jobs. So how do you achieve the goals of money, wealth, and prestige? Well, one possible solution that Merton suggested was you achieve success by innovative, illegal means. Actually, Merton called criminals innovators. It's kind of unusual. He has promoted criminals to the same level as scientists and inventors. So what does this mean in terms of assessment? You know, if we go back to the Lombroso theory, if you adopt this theoretical perspective, your risk assessment will involve some sort of indicator of poverty, some sort of indicator of being in a disadvantaged position within society. So notice here that the potential risk predictors are very few. If you're thinking of treatment, well, you see on the other side of the slide what kind of treatment interventions would be available to you in order to reduce risk. Even some of the other sociological criminological theories, they may look like they're measuring psychological factors. The old gang theories, you know, you feel alienated from society, you have poor self-esteem, so you join groups in order to feel better about yourself. You join gangs. But even here, the root cause is social. Society is preventing some segments of the population from engaging fully in society. And even the treatments, you can see examples there. Non-intervention, that comes from labeling theory. You know, if you label somebody as criminal, they're going to start acting like a criminal. They identify as a criminal. And so the best thing you can do is do nothing, don't intervene. As a researcher, a scientist, the most important thing is, what is the evidence? And if we look at the evidence for lower class, this coming from a minority and the like, the evidence is quite weak. The average effect size correlation coefficient there is 0.05. That's very close to zero. Now, to be fair to sociological criminology, it has come a long way since Merton and the subcultural theories in the 50s and 60s. We now have theoretical perspectives that talk about low self-control, strains within the family and the work. Criminology today has become, in a sense, very psychological. So that's the sociological perspective. The forensic psychopathology models. Now this is interesting because here we go to the other far end of the spectrum. The cause of crime is now within you. It doesn't matter where you are in terms of your socioeconomic status. It's your feelings, your emotions, your thinking that becomes very important. That's the cause of crime. So if we now turn to the implications in terms of assessment and treatment, there you have some of the examples you may have in a risk scale. If you're highly anxious, increased risk. Cognitive deficit, poor self-esteem. These can all contribute to your risk assessment. And as you see, it also has implications to treatment. I will frequently come back to this issue of treatment because my view is good offender risk assessment should not only differentiate low and high risk offenders, but it should also inform your interventions to reduce risk. In the introduction, Daniela mentioned that I started my career in a maximum security detention center. And while I was at that detention center, I would conduct various research studies. Now, I was trained as a clinical psychologist. I was trained to believe that the problem of men and women can be found in some sort of psychopathology or disorder in thinking and feeling and behavior. So one of the things I did was I administered a psychological test battery. And because of my training, I selected measures based in this psychopathological view of behavior. 1 year later, we looked at the outcomes. Self-esteem, anxiety, locus of control did not predict criminal recidivism. They were irrelevant. The only interesting one that predicted was depression, and that was in the negative direction. That means that the more depressed you are, the less likely you are going to reoffend. Now, if you're a good evidence-based clinical psychologist, what you should be doing at this point was encouraging depressive feelings among your inmates, because this would reduce their recidivism. Well, although I was tempted to do that, I didn't do that. Instead, I tried to replicate the study, asking myself the question, how could this be wrong? All my training in clinical psychopathology not being relevant to criminal behavior. When I replicated the study, found essentially the same findings, but this time, of course, the depression became non-predictive of criminal recidivism. Now that's a little bit of an anecdote, a story from me, but if you look at the broad literature, meta-analytic reviews, measures of personal distress, feeling blue, feeling anxious, feeling out of sorts, so to speak, showed very low correlations with future criminal behavior. Now, people can look at this finding and accept it, saying, well, yeah, if you're feeling a little bit down in the dumps and so on, I feel like that now and then, so I'm not surprised to see this kind of a finding. But certainly, let's suppose you go to the extremes of personal distress and you have a serious problem. Certainly, that should correlate with future criminal conduct. Well, in a large meta-analysis that we did a couple of years ago, what you find is some of the major mental disorders, and here's two examples, schizophrenia, mood disorder, were largely unrelated to criminal recidivism, and if anything, in the inverse direction. The schizophrenic is less likely to engage in general crime. The mood disordered, bipolar, less likely to engage in general and violent recidivism. MDO stands for mentally disordered offender. And this is where you take studies that compare a mentally disordered offender with a non-disordered offender. And what we find is having a major mental disorder compared to a criminal non-disordered population makes you less likely to engage in general and violent recidivism. So let's turn now to the general personality and cognitive social learning perspective. This is part of the general class of theories referred to as social learning theory, but it's a little bit more specific for criminal conduct, and it has been described by myself and my late co-author Don Andrews since the 1980s. Here are the basic ideas. First of all, behavior, criminal or non-criminal behavior, is learned according to well-known principles. Classicals, Pavlovian, operant, Skinnerian, rewards and punishments, vicarious, watching a model do the behavior. These are well known in psychology, and these principles apply to the learning of criminal behavior just as it applies to learning how to ride a bicycle. This learning depends on personal factors within the person, their thinking, their feeling, people around them, interpersonal factors, and the immediate situation can have an impact. And these factors interact with person factors. Not everybody responds to rewards and punishments in the same way. The social context is terribly important. Learning does not occur in a vacuum. They occur in the major settings of home, companion, school, leisure, recreation. Right? Rewards and punishments occur specifically for certain behaviors in these settings. So in a work setting, you are rewarded for showing up on time, leaving at the appropriate time, producing so many widgets per hour. You receive rewards for that specifically. And as I mentioned earlier, person factors are terribly important. The way you respond to rewards and punishments will differ depending on your thinking style and your personality. Rewards and punishment do not work the same way for all people. So telling somebody, I'll give you $50 to do behavior X, that will work maybe very well for a homeless person, but it will not have any impact on somebody like Bill Gates, right? So you have to consider certain personality, person factors to understand how rewards and punishments occurring in these major settings are going to work. Now, in our theoretical perspective, we talk about the central 8 risk-need factors. Criminal history is an indicator of your reward history for criminal behavior. If you have a long criminal history, it is apparent that you have been receiving lots of reinforcement for criminal behavior and very few punishments for that behavior. Antisocial personality pattern is the impulsive, callous, emotionally restless kind of individual, the person with a chip on his shoulder. And then you could see how pro-criminal attitudes can influence criminal behavior. The people you hang around with, your family, your education and employment situation, and so on. 7 of the central 8 risk-need factors are dynamic. They can change. You can make new friends, you can lose friends, you can start taking alcohol, you can stop, you can find a job, you can get fired from a job. So this is very important in the development of risk assessment instruments. This idea of the major risk-need factors being changeable and being dynamic. So to summarize up to this point, you look at these 3 broad theoretical perspectives, and from them you could see the types of risk factors that are derived from these theoretical ideas. And the general personality, cognitive, social learning perspective is perhaps the most comprehensive of all the theoretical perspectives. It puts out a rich variety of factors that should be addressed in assessment. The relationship between general personality and cognitive social learning theory and the RNR model. Sometimes people get them a little bit confused, but first we have the theory that tries to explain criminal behavior and give us an understanding of the causes of criminal behavior. The risk-need responsivity model is essentially an application of general personality and cognitive social learning theory. It takes elements of the theory and guides us in developing assessment and treatment programs. Sort of like a theory of evolution. Theory of evolution helps you understand how people have developed certain kinds of characteristics and temperament. Understanding that then allows you to perhaps design interventions. You may go out and purposely design an environment to selectively breed dogs to do certain kinds of behaviors, such as shepherding sheep. There are 3 important principles in RNR. There are many more principles described in the book, but here are the 3 major ones. The risk principle: match treatment services to the risk level of the individual. Target the higher risk. For low-risk offenders, do less. For high-risk offenders, you need to do more. And you can see theoretically, this comes from the central 8 idea. Right? The more of the central 8 an individual has, the higher their risk will be. The importance of learning principles. When you have a great deal of prior convictions, that means you had loss of reinforcement for criminal behavior. The next principle, the need principle. target criminogenic needs in treatment. Criminogenic needs are the needs of offenders that have been empirically shown to be related to criminal behavior. Not all offender needs are criminogenic, and the central 8 are the major criminogenic needs. A client may have poor self-esteem, and you may look at it as, oh, that's a need that the person has, so therefore I will build up his self-esteem. That won't achieve you what you want. You may end up with having a self-confident criminal. The responsivity principle: match the treatment style to the offender's learning style. There are 2 aspects to responsivity. First is general responsivity. Most offenders respond best from cognitive behavioral interventions. Offenders, their person factors are concrete oriented, tend to live in the here and now. And cognitive behavioral techniques have a lot of role playing, a lot of concrete types of practice that are well suited to many offenders. Specific responsivity talks about modifying your intervention to some specific emotional, personality, motivational factors. So, for example, you may approach a female offender differently from a male offender because of differences in the way they learn. Now, this is all nice. Theoretically, it all may make a lot of sense, but what's the evidence? Well, this slide is a summary of treatment interventions, and we break up over 300 treatment studies into terms of how well they follow the RNR principles. The closer a treatment intervention follows the RNR principles, the greater the reductions in recidivism. So as you see at the far right, if you have a treatment study that can follow all 3 principles, they're targeting higher risk offenders, criminogenic needs, using cognitive behavioral programs, they're going to have the greatest impact. What does this mean for risk assessment? At the minimum, a good risk assessment instrument should be sampling the central 8, include as much as possible dynamic risk factors, criminogenic needs, and the assessment should inform treatment. The evidence indicates that the central 8 risk need factors are predictive across different offender populations. We have general offenders, mentally disordered offenders, and sex offenders, and they're all roughly in the same ballpark. This is important because the general personality cognitive social learning theory is a general theory of criminal conduct. We don't have a white-collar crime theory. We don't have a specific theory for just women offenders. The perspective tries to encompass most offenders. Let me now move to the third part of the presentation and looking at how offender assessment has changed over time. We have first generation unstructured clinical moving to second, third, and this is where we first see the LSIR, and going to fourth generation where we find the LS CMI. The research on first generation risk assessment clearly indicates that in terms of predictive accuracy, you are not much better off than flipping a coin. When you compare it to second to fourth generation, the clinical first generation is all around the 0 mark, 0.03, 0.05. Now, what about second generation risk scales? Let me give you an example of what they look like. We have the salient factor score in the United States, the SIR in Canada, and we have one in England. Now, there's just two things I want to point out here. One is that these second generation risk scales tend to be relatively short. You know, the SIR has, I think, around 15 items. They don't have a whole lot of items. And by far, most of the items are static. They're unchangeable. You cannot do anything about it. Now, the point here is that these second generation risk scales do predict criminal behavior, and they predict it quite well. However, if you're a practitioner, a parole officer, a probation officer, the only information it really gives you is, oh, he or she is high risk or medium or low risk, but doesn't give you any information on how do I reduce the risk of this individual. Well, maybe in the Canadian SIR score, the only guideline for treatment is to find the person a job, get him married, and have him go out and adopt 5 or 6 kids. That's the limit of what it can do to inform treatment. Third generation, we come to the LSIR, Level of Service Inventory Revise. Now you'll see most of the Central 8 risk need factors reflected in the LSIR. It's not there completely 100%, but most of it is there. The LSIR was the first risk need assessment instrument to integrate both risk assessment and criminogenic needs. Around the same time, there was another instrument, the Wisconsin Risk Classification Instrument, but they had 2 separate scales, one a static risk scale and a second need scale. And there are advantages to this kind of intervention. You have all the information you need in one document that helps you assess criminogenic needs. 2/3 of the items in the LSIR are dynamic, and changes in scores have been shown to relate to recidivism. So if 1 year later an LSIR score goes up, higher risk, you know that whatever you're doing is not the right thing. The person is becoming worse. And if the scores are going down after a year, that's great. Whatever you're doing, you're on the right path. Keep going. So it has the advantage of not only identifying treatment goals, but monitoring progress during supervision. Fourth generation. How do we get to this? How do we get to the level of service case management inventory? We did a study in the province of Manitoba, which is in the center of Canada, where 62 probation officers from the province of Manitoba had agreed to have us audio record their supervision session. So I thank those probation officers, because it is not easy to open up what you do behind closed doors to outside researchers. So when we looked at the audio recordings, what do we find? Well, probation officers were very good at dealing with family, marital, substance abuse issues. You see them coming up in their recordings. But if the problem was around your friends or your attitudes, they just weren't there. So we felt that in the province, they were doing their risk need assessment, and almost it appeared like filing them away and then going into their supervision sessions, forgetting about what they assessed and what they need to be talking about. And that's one of the products that came out of this research. So you look at the LS-CMI, yes, we added more information, but more importantly, we introduced a case management plan and a progress record within the same document, which made it more difficult for a probation and parole officer to lose sight of what was relevant with that offender. You'll also notice with the LSCMI, we now completely matched up the subcomponents of Section 1 with the Central 8. So we tied it in much more closely with the theoretical underpinnings. The research with the adult versions of the level of service instruments, and I would like to note for listeners, there is also a youth version of the level of service instruments. And there's a youth level case management instrument that I would encourage you who are working with youth to take a look at that instrument. And there is a great deal of research on this instrument and its predictive validity and its usefulness for practitioners. But for this webinar, I am just staying with the adult versions. Research with the LS is the most widely researched risk needs instrument in the world. There are studies, not only studies, but meta-analytic reviews with male and female samples. We have studies with indigenous populations, Hispanic, Asian. The research has been done on probation and parole clients with prisoners, inmates, even specialized groups such as sex offenders, male batterers, and mentally disordered offenders. In terms of prediction, there is data on predicting arrests, convictions, incarceration, even violent offending. In fact, when you look carefully at the research evidence, the LS instruments predict violent outcome as well as any specialized violence risk assessment scale. And of course, we have parole and probation violations and prison misconducts. I think for the practitioner, those of you who are working at the front lines with clients day in and day out, depending on the setting, it could be useful for you in preparing sentencing decisions. In many jurisdictions, LS instruments are the foundation of many pre-sentence reports. And what's interesting here is we have never advocated for using an LS instrument to encourage incarceration, to lock people up, to give the hardest response. In fact, because we emphasize the treatment integration with the LS instruments, our sentencing decisions should be informed, yes, by the risk of the offender, but also providing information to the courts on how that risk can be potentially managed in the community. And similarly, you can see the same kind of approach with release decisions from prisons, even mental health review boards. The LS instruments help you with intervention. It identifies the criminogenic needs that are vital for treatment planning. With the LS-CMI, we have in it opportunities to outline a case management plan that is evidence-based and based on the risk-need assessment of that client, and allows you to monitor progress throughout the supervision period. So in summary, theory is nothing more than a way to explain behavior and understand behavior, and hopefully understand the cause of behavior. I talked about sociological criminology, psychopathology. These theories are all saying something right. They're getting part of it, but they're like the blind man and the elephant. They don't see the whole picture. And I hope that understanding GPCSL theory helps you see the whole picture. The RNR model is derived from the theory. The evidence for risk-need responsivity is almost at the point where it is unquestionable. In terms of risk assessment, I've outlined how we've progressed over the years, and we're now at the third and fourth generation, the level of service instruments. And once again, I'm going to leave you with the important point: there's more to risk than simple prediction. If that's all you want to do, use a static second generation risk scale. But if you want to reduce risk, you need to inform treatment. You need a risk-need assessment. And only the third and fourth generation instruments will do that for you. So I thank you very much, and I believe we have some time for questioning.
Okay, thank you so much. Yep, we've had quite a few questions come in. Just before we get to the questions, I just want to remind everyone on the phone, if you haven't had a chance to download the material in the handout section, please do that before you log out of the webinar. I should also mention that as soon as you do log out of the webinar, you will be presented with a feedback questionnaire. It should only take 30 seconds to a minute, so please, if you get a quick chance right after the webinar, complete that feedback for us. And I should also mention that we have been recording this session. So if you want to review it later, or if you have a colleague or two that wasn't able to attend, we will be sending out a link to our YouTube channel where you'll be able to view the recorded session in the next few days. Okay, so let's get to some of the questions. One question that came in is, what is the definition of accommodation?
Okay. The accommodation subcomponent is in the LSIR. In the LSCMI, it is embedded in the antisocial personality pattern subcomponent. So accommodation is, we're looking at, let me try to explain this from a theoretical perspective. When you have someone who is frequently changing accommodations, 3 or more address changes in the last year, what does that indicate to you? Well, one is that that person is getting very little reinforcement, very little pride from a stable, pro-social living environment. So person who is moving around like that will end up being free to engage in crime, so to speak. Because if you get caught for a crime, would you like losing your house, the place where you lived in for year after year? There's a huge punishment involved there. But if you have unstable accommodations, you don't have that kind of control over you. And of course, one of the other items is living in a so-called criminogenic neighborhood. And that's where you're in a residential neighborhood where everybody, or not everybody, but many of the people around you are engaged in crime. So what does that mean theoretically? Well, you have lots of people modeling criminal behavior for you, and you have lots of people who act as potential sources for rewarding criminal conduct.
Excellent, thank you. We have another question. Someone says, I use the LSIR. What is the difference between it and the LSCMI tool?
Right. The LSIR was published in 1994, and the LSCMI came out in 2004. There are a number of differences. First of all, I just want to reassure people who use the LSIR, it does predict, it does help you in identifying treatment targets. And in fact, in the LSCMI, Section 1 is almost 90% the same items as in the LSIR. And in fact, for researchers, you can convert one LSIR score into LSCMI scores and back. The major improvements in the LSCMI are the new sections that look at another more comprehensive list of potential risk need factors, such as being involved in domestic violence, sexual offending against children. Theoretically, what's also important, we now have a responsivity subcomponent, which could help you in designing treatment interventions. And of course, as I tried to show in the presentation, we have the case management subcomponent and the progress record. So in the case management subcomponent, you are given the opportunity to identify what the major criminogenic needs are for that individual and what you're going to do about it. What's your plan on intervening, and what are your target dates? How long is it going to take you to, let's say, work with this guy to find a job? And the progress record is a way of ensuring whether or not you are on track in addressing the criminogenic need.
Okay. A quick question. What is the name of the adolescent version that you mentioned earlier?
Well, it's actually the youth version, and the LSIR and the LSCMI can be used with clients age 16 and over. The youth level of service inventory is specifically for those under the age of 16. And what you'll notice theoretically is the same central 8 play into account, but for example, in the youth version, you will have more items on school and very few items on employment, right? Because a 14-year-old is not working, or I hope not working.
Okay, excellent. If multiple domains are high, which should be addressed first?
Now that's a really good question, because for those of you who deal with medium to high risk offenders, one of the first things you'll see is they're going to score high on almost all those domains, and your head may spin. Where do I start? What do I deal with? Now at this point, we don't have very, very strong evidence for it, but I am now leaning towards looking at the attitudes. Now, pro-criminal attitudes are very specific to crime. You know, when they say it's okay to steal because they're insured, that's very specific to crime. But if you have somebody with criminogenic needs, let's say employment, substance abuse, you can ask yourself what's underlying that. And you will always find that there's an attitude behind it. So for example, employment. The client will say, why should I work? Only suckers work. You know? So you may want to start looking at some of those underlying attitudes to help them change and address properly their criminogenic needs.
Thank you. Can the LSCMI be used with offenders with learning difficulties?
Well, we don't have any research specifically on that, There may be, but I don't see why not. First of all, remember, when you're conducting an LS interview, there is an interview process involved. You are also encouraged to investigate through collaterals, family members, teachers. So if you have someone with a learning disability, let's say, or some sort of cognitive deficit, and you're not sure about a certain aspect in the scoring of an LSI or the LSCMI, you go out and you talk to teachers, you talk to a family member. The level of service instruments are all about getting the best, most comprehensive assessment of this client that is important for reducing recidivism.
Okay, and I think we have time for one last question. Which LS tool is best for informing sentencing decisions?
There is no research saying LSIR or LSCMI is better than the other. The LSCMI will give you more information with other potential risk need factors, and also it more objectifies the case management aspect of planned sentencing.
Okay, great. We only have a couple of minutes left. I don't think that's enough time to take any more questions, but I just want to take this moment to thank Dr. Bonta for taking the time out of his day and week to come here and into our studio and present on this topic. I'd like to thank everyone who attended today's webinar for taking time out of what must be a very busy day for you as well. Again, once you close out the webinar, you'll see a feedback. We'd love to hear from you, what other topics you might be interested in, as well as how you found today's webinar. So again, thank you everyone for participating, and we'll sign off now. Thank you.